Lots of patients who are watching this segment are tuning in from all over the world. Some patients are located very close to centres of excellence with an internationally renowned reputation. How important is it, if there is a concern about a diagnosis for lung cancer, is it to get the biopsy done at a centre of excellence as opposed to your, for example, local community hospital?
So I have a split experience now. I spent the first 10 plus years in a high-powered academic center, MD Anderson in Houston, and now have spent the last 7 years in a community-based, front-facing organization, community hospital at Levine. And it really is dependent on the local practice. I think you're going to be more reliable going to an academic center because there are other people that are holding them accountable. I think I've seen high quality work in the community as well. We have a group of pulmonologists, for instance, that are fantastic and they do a lot. They can biopsy things that I didn't think were possible with good pieces of tissue. Mm-hmm. But I think you also see that variability. I have seen some patients come in with just a brushing or not even an attempt. And you need to have that. And I understand everybody's degree of risk and degree of skill set is different, but absolutely you have to have a biopsy that is confirmed. And if you're uncomfortable with where you're at, because many times patients feel like they shouldn't go out of their small community. They've known this doctor or that doctor for the last 20 years and their parents were friends with their parents.
Sure.
Look, I tell people if there's any time in your life that you need to be selfish, it is now. We need to get an accurate diagnosis up front. We don't want to start the wrong treatment or start in a different manner. It's always best to have your best treatment up front and give it the best shot.
So a patient comes to your office, they've had a biopsy performed already locally, and they're coming to you for a second opinion, and you have the pathology reports in front of you. Do you think it's important to get a reread on that pathology and have one of your experts look at the slides again and make sure that that diagnosis is correct and that there's agreement, or more often than not, is that good enough, what's on the report?
I like to have our own folks do it. And that doesn't mean you send everything to Levine. Clearly, we all work with different people on our team. We know who we're comfortable with. I think it never hurts to have another set of eyes looking at something. There were countless times at MD Anderson where we changed the histology diagnosis enough that you would not trust just an outside report. Mm-hmm.
So I think that's an important message for people watching this segment, that if you've been diagnosed elsewhere, a second opinion is paramount, not just to discuss different treatment options, but also to have a second look at the pathology. Do you ever have the situation where a patient may have had a biopsy of 2 lesions in the lung and that the pathology is different? So maybe they have a small cell and a non-small cell at the same time?
Yes, I've had several of those, and I think that is very important to look at how the disease is distributed. That doesn't mean we want 2 biopsies on every patient who comes through the door, but when there are potentially different treatment options, if the 2 lesions or others were different histologies, then I think it's important to have 2 biopsies. Where it gets a little complicated now is that we are now doing molecular testing, and we will see 2 of the same histology, but have different molecular markers. Not so much in small cell, but we're seeing that more in non-small cell, which then makes it additionally challenging because we're knowing that we have 2 genetically different tumors, even though they look the same under a microscope.
And we're going to be talking about the role of immunotherapy, and challenging, yes, when there's different molecular backgrounds to these tumours, but also very exciting, isn't it, for development of future drugs and immunotherapies to offer patients targeted, precision-based treatments?
I will admit I was not one of the early card-carrying immunotherapy champions out there. I had been working quite a bit with different vaccine trials and other aspects that just didn't show much promise. But these checkpoint inhibitors have really transformed our care.
And not just in lung cancer, in other cancers as well.